Hello, my name is Carolyn LeBeau, and I'm a perioperative echocardiography fellow and clinical visiting instructor at the University of Utah. Today I'll be discussing common cognitive errors encountered in perioperative decision making, specifically pertaining to echocardiography. I have no disclosures. When talking about the field of decision making and cognitive reasoning, we have to start with a landmark article published in Science that is cited by most every major paper in the field. In 1974, two psychologists, Amos Tversky and Daniel Kahneman, described a framework to help explain current theories about human decision-making and judgment. They theorized that individuals process information and make estimates and choices through the use of heuristics. Heuristics are our intuitive thought processes. They are mental tools that we use to allow for reflexive thinking and cognitive processing with limited amounts of information available. Heuristics help us make rapid decisions. But with the benefit of expediency, we can potentially sacrifice our accuracy. From the body of work of Tversky and Kahneman, the dual process theory has emerged as the predominant approach to explain reasoning. This model describes two systems of decision making. Heuristics exist in the first type of thinking, called type 1 thinking or fast thinking, and this is the ability of the brain to think and act intuitively. This is the type of thinking that is prone to cognitive biases. System 2 thinking is our slow, analytical, deliberate approach to decision making. These types of thinking can be translated into medicine. As physicians become more seasoned, their cognitive processes become more routine, more like type 1 thinking. Much of the data on cognition in medicine, specifically when it comes to cognitive processes and image interpretation, is out of the field of radiology. To give an example, we have experienced radiologists using their seasoned type 1 thinking, and they may reach a diagnosis without much conscious deliberation in a matter of minutes. However, the heuristics that they use may fail to achieve the correct diagnosis due to inherent errors in our thinking called cognitive biases. Contrast that to a first-year radiology resident, where they may carefully review an abdominal CT study and consciously think about each structure in a checklist. Such a review, using predominantly deliberate type 2 thinking, may take an hour to reach a conclusion. However, this type of thinking is most likely to facilitate the correct diagnosis. Okay, so what does this dual process theory of reasoning look like? A main publisher in the field is Pat Crosscarry. He is an MD PhD who originally trained as an experimental psychologist, who then went on to become an emergency medicine physician and is currently a professor at Dalhousie University in Halifax, Nova Scotia. He has worked on the adaptation of the dual process theory of reasoning for medical decision making. So here we have our model, and remember that System 1 thinking refers to the intuitive, unconscious manner in which we make most common decisions. System 2 thinking is our deliberate decision making. The model begins with the initial presentation of a patient, and that presentation has a pattern that is either recognized or not by the observer. If it is recognized, the parallel, fast, automatic processes of System 1 thinking engaged. If it is not recognized, the slower analytical processes of System 2 thinking engage instead. System 1 processes engage immediately and automatically. This process is reflexive and unconscious. There is no deliberate thinking effort involved. If the patient presentation is not recognized, or if the presentation is ambiguous or uncertain, then System 2 processes engage instead. Now the system is an analytical one, attempting to make sense of the presentation through objective and systematic examination of the data. It is a linear processing system, slower than System 1, more costly in terms of investment and resources, but considerably less prone to error. The model has several mechanisms for modifying its output. First, System 1 and System 2 may interact with each other so that the final output is a synthesis of the two. The monitoring capacity of System 2 over System 1 allows it to reject System 1 thinking by applying rational override. So, if at first look, the mobile echo density on the aortic valve may trigger an endocarditis diagnosis, but if there are atypical features present, System 2 thinking can override and force a reassessment. It has been suggested that most common cognitive biases are likely due to the overuse of System 1, or when System 1 overrides System 2. Clearly, medical reasoning and decision-making do not fall neatly into either one of these systems, and there is obvious interplay between both of them. but this model aims to provide a basic framework for medical decision making. Okay, so why am I talking about this today? Well, our thought processes and medical decision making are similar to this model, and as echocardiographers, we must acknowledge our susceptibility to cognitive biases. Let's go through a couple cases from the University of Utah that exemplify just how susceptible we are. Our first case begins with a 67-year-old who presented to the OR for normal EF CABG. Here are some images from his pre-bypass TEE. In the mid-esophageal long axis view, we see good opening and closing of both the aortic and mitral valves, with no evidence of turbulence in the left ventricular outflow tract. The post-bypass TEE was unchanged from prior and showed no gross abnormality. So the way that our echocardiography service works at the University of Utah is that we have a designated anesthesiologist on call 24/7 that is certified in both advanced perioperative and comprehensive echocardiography. So in this specific patient, our normal EF CABG was no longer responding to fluids and had an increasing pressor requirement that same evening postoperatively. The same anesthesia attending who had read this patient's echo earlier in the day, Dr. Josh Zimmerman, got called by our ICU team. What would you do? As an echocardiographer, having performed a TEE hours earlier with no major findings, what would you think of this patient's current status in the ICU? So Dr. Zimmerman goes in and heads to the ICU, drops a probe, and this is what he sees on TEE. Here we see evidence of left ventricular outflow tract obstruction from systolic anterior motion of the anterior mitral leaflet with significant mitral regurgitation. The development of LVOT obstruction is not the main point here. What warrants discussion is the cognitive bias experienced by our echocardiography team. The patient had 2 prior imaging studies, his pre-bypass and post-bypass studies, that show no evidence of LVOT obstruction. The echocardiographer thought, how could this be LVOT obstruction? Why would it be that? We've ruled it out. What he experienced was anchoring bias. Anchoring bias is the tendency to mentally lock on to salient features of the patient's presentation too early in the diagnostic process and subsequently failing to adjust this impression in light of more current clinical information. So with the new information of the patient's clinical status changing in the ICU, our diagnostic process must be able to change to account this new information. So what can we do? The overarching goal of the strategy to combat anchoring bias is to seek to disprove the initial diagnosis. If something doesn't fit, ask a second opinion and get your colleagues involved. After making a diagnosis, you need to ask yourself, what else could this be? What else have I forgotten to consider? Our second case is an endocarditis patient. He is a 37-year-old male IV drug user admitted to the ICU with MSSA bacteremia. At the Salt Lake City VA hospital, our echocardiography lab is run and staffed predominantly by anesthesiologists, and our responsibilities not only include performing and interpreting perioperative echoes, but all outpatient and inpatient echoes that occur at the VA hospital. So with this patient, our echocardiography team was consulted to perform a TTE for endocarditis evaluation, and this attending goes to do this echo on this patient in the ICU. This is what we see. These are the TTE images obtained by our team. You see no evidence of valvular vegetation, valvular regurgitation, or abscess. Rightfully so, the medical team had a high level of clinical suspicion for endocarditis, so the next day our echocardiography team, actually the same attending, performed a bedside TEE to further evaluate for endocarditis. And this is what we see on the next day. These images show a large vegetation on the posterior mitral leaflet associated with severe mitral regurgitation. So naturally, the echo attending reviewed the TTE images from the day prior to determine if he had missed something. But even multiple echocardiographers in our lab were unable to find any evidence of a vegetation on the transthoracic images. So what happens now? The moral of this case is not necessarily what happened to this specific patient, it is what happened after. In speaking with this specific echocardiographer, he stated that over the next couple of months, all he could think about when interpreting images, especially in the setting of endocarditis, is that he may be missing something. He said he felt his sensitivity for detecting a vegetation dramatically increased, while at the same time his specificity plummeted. He was experiencing the availability bias, or the tendency for easily recalled or recent experiences to influence decision making. It was clear that after this experience, the availability bias was continuing to influence his further clinical care. So, what can we do to combat this bias? First, we need to remember the objective data on the probability of that specific finding. And we need to create a differential before diagnosing a patient with an otherwise recent or memorable diagnosis. Our third case involves more endocarditis. A 66-year-old male with a past medical history of prior mitral valve replacement and recent stroke presented urgently to the operating room for a redo mitral valve replacement for endocarditis. Here are the pre-bypass images. We see dehiscence of his mechanical mitral valve associated with severe mitral regurgitation and paravalvular regurgitation. Further images also showed a very large vegetation on the mitral valve. In speaking with the intraoperative echocardiographer, the findings of the dehisced mechanical mitral valve and large vegetation were so captivating that it was difficult to stop seeing the obvious when interrogating the other anatomic structures of the heart. All of the team members, including the surgery team, were so satisfied with what they saw as the reason for the patient's clinical decompensation, this dehisced mitral valve, and so they went on to replace the mitral valve. But when the study report was being finalized later that day, the echocardiographer saw something in the aortic valve short axis view that could be interpreted as a vegetation. Luckily, it was interrogated in multiple other views, and it turned out that this potential vegetation was actually an artifact. But what if it wasn't? Intraoperatively, everyone was looking at the images, and everybody was so captivated by the mitral valve that this potential aortic valve vegetation was overlooked. This endocarditis case exemplifies another commonly encountered cognitive bias called satisfaction of search. In this case, the elephant in the room was the glaring mitral valve endocarditis, but it was quite possible that the aortic valve artifact could have actually been a vegetation present and would have been missed, all because the echocardiographer's eyes fell subject to being satisfied. Satisfaction of search occurs when the visual search pattern is discontinued when the first abnormality is found that can explain the patient's clinical presentation. This is a bias that plagues radiologists. In fact, a 2013 study by Kim et al. That looked at classifying types and prevalence of radiologic diagnostic errors found that 22% of errors were related to satisfaction of search, which was only second to errors classified as underdiagnoses or misses, making this the most common cognitive bias in diagnostic radiology. So what can we do about satisfaction of search? We can use a systematic approach to ensure all relevant findings are identified. After completing a primary search, we need to initiate a secondary survey. Finally, we need to keep in mind related diagnoses and common diagnostic combinations to ensure we don't miss any commonly associated findings. Our last case, we have a 77-year-old male with a past medical history of CAD who had a CABG, who was admitted with acute decompensated heart failure. The patient was found to have severe functional mitral regurgitation, and the cardiac surgery team proceeded with mitral clip placement. The placement went fairly smooth, and the patient was admitted to the ICU after the procedure for continued ionotropic support. Shortly after the procedure, when the patient was in the ICU, our echocardiography team was consulted by the surgeon for clinical decompensation. The surgeon stated, "I think this patient's right ventricle may be failing. Could you take a look?" Here were the TEE images of that patient, and you can clearly see there's no overt evidence of right heart failure. With the clinical question answered, our echocardiography team finished capturing the rest of the exam images. When interrogating the mitral valve, there is evidence of new severe MR that was new since the procedure and was likely evidence of dehisced mitral clip. It was a good thing that our echo team was able to image this finding, and they didn't merely attribute this patient's declining clinical status as not RV failure. In this circumstance, our team, if they had stopped imaging after the RV looked okay, could have potentially experienced framing bias. Framing bias is the phenomenon in which diagnostic reasoning is influenced by how the clinical question is presented. If the question posed to the echo team was, "Why do you think this patient isn't doing well?" instead of, "Is the RV failing?" it may have been even more likely for our echo team to see the dehisced mitral clip. So what can we do? We need to step outside our clinical framework and consider the whole patient picture. I know it is sometimes difficult, but if possible, we need to interpret our images first while blinding ourselves to the clinical concern. And finally, you need to ask yourself, would I have still made this diagnosis if I had a different clinical history? This is a great review article from the field of radiology published by Busby et al. In 2018 in Radiographics. It covers common cognitive biases experienced by radiologists and offers some solutions on what to do when our thought processes get compromised. From this article, some systemic strategies we can employ include the reduction of interruptions while interpreting images. Intraoperatively, I know this sounds impossible, but interruptions can contribute to all sorts of cognitive biases, particularly satisfaction of search, as our mental memory is compromised to address the interruption. This paper suggests designating an individual to manage non-interpretive tasks to decrease disruptions experienced by the image interpreter. This might be someone dedicated to taking care of the anesthesia while the echo is being performed and interpreted intraoperatively. This article then goes on to talk about the importance of participating in echo QA conferences and creating a peer review program with a positive culture at its forefront. We know that peer review programs that aim to establish an environment where errors are instructive rather than punitive support an atmosphere of cognitive debiasing. Finally, this article discusses how to employ cognitive debiasing strategies. And we already went over a couple of these. It presents this table entitled Questions to Guide a Strategic Approach for an Unbiased Interpretation. We've covered some of these already. Questions like, what cases have I seen often or recently that might impact my interpretation? This is getting at the availability bias. Or, what information or diagnoses have I forgotten to consider? This is getting after the anchoring bias. Or, would I have made this diagnosis if I had a different clinical history? Getting at the framing bias. And finally, did I adhere to my primary and secondary search patterns, which is tackling satisfaction of search. A paper published by Eli et al. In 2011 in Academic Medicine highlights the importance in the use of checklists in an attempt to minimize diagnostic error. It is widely known that the use of checklists has been shown to reduce errors in a variety of fields and in multiple aspects of medicine. This paper reminds us that checklists help resist biases and heuristics that lead to diagnostic error. Checklists decrease our reliance on our rote memory. They help us consider a comprehensive differential diagnosis. They allow us to take a step back from immediate problems to examine our thinking process. And finally, checklists allow us to recognize our altered mood states that arise from fatigue and sleep deprivation. At the University of Utah, this is one of the checklist-type cognitive aids that we use when performing our rescue echoes. This cognitive aid is extremely helpful when the stress of performing, interpreting, and guiding clinical care is at its highest. You can see that the checklist is broken down into the different shock states, and in the middle it provides a guideline for specific views to capture and modalities to use to aid in diagnoses. What else can we do? We can practice metacognition. The concept of metacognition was first introduced in 1979 by Flavel et al. In the American Journal of Psychology. Metacognition is a multifactorial process where we reflect on our own thought processes, or we think about our thinking. It helps us to acknowledge the limitations of our memory, and it helps us to seek perspective when making decisions. Metacognition has been suggested as a way to minimize errors in type 1 thinking. This can be done by the deliberate incorporation of type 2 thinking strategies. So what else can we do? We can raise awareness and educate. We need to make physicians of all levels aware that our thinking and diagnostic processes can be compromised. All medical specialties, especially the ones with a heavy emphasis on image interpretation, need to implement an educational curriculum for trainees and staff. In fact, many papers state that awareness that errors can be made is arguably the most effective strategy we have to reduce cognitive bias. If we can work to familiarize ourselves with the major classes of cognitive bias, then we can help ourselves predict the various circumstances in which we are prone to error. There is some hope on the education front. This is a 2013 study published by Riley et al., and it was published in the British Medical Journal of Quality and Safety. This was a study where they implemented a year-long curriculum in diagnostic error and cognitive bias during an internal medicine residency, and the final evaluation at the end of the year showed a statistical improvement in residents' knowledge and recognition of cognitive bias. This paper suggests that introducing educational content during the training period of physicians, medical school, and residency, when these decision-making habits are being formed, can enhance future decision-making through increased knowledge of reasoning. If you took something away from my talk today, I hope it's the fact that heuristics and type 1 thinking are not inherently bad. They are just subject to cognitive bias, and we need to be aware of this, especially in the clinical setting. I hope it's obvious to you that we need type 1 thinking to function in our day-to-day life. If you had to think about every single decision you made in detail, you wouldn't make it through 10 minutes of your day. Finally, I want to encourage everyone to start considering our own cognition and its inherent flaws, especially in the setting of image interpretation. Remember that we are not perfect and that our mental processes are subject to error. Thank you for letting me talk about what I think is this fascinating subject, and I'd be happy to answer any questions.